Joseph Leve to deliver the next talk.
Thank you, sir. My screen is visible. At the outset, let me thank the organizer, ISA, especially Professor Batma and Professor Rohit for providing me this excellent opportunity. Professor Ajay's extensive lecture has limited my role to specific areas. I won't call them as advanced imaging because these are CTA, CTP, and MRI are almost basic tools in the evaluation of stroke nowadays. Our institution, the CT is the main workhorse, mainstay of this strokes diagnostic workup because more than anything,
we need to mute some of the, I think. Yeah, thank you.
Yeah. I was telling that in our institution, CT forms the mainstay of the stroke workup. More than anything else, logistics has dictated this practice because MRI is physically little removed. So our experience is also much more in CT and CT angio. Let me come to the CT angiography. CT angiography, I can approach it as three definite roles. One is diagnostic, meaning the locating the cause for the stroke, vascular, that is seeing the pipes, and another is decision making in difficult cases, whether to intervene or not, or if you intervene, what type of intervention, and it forms an important factor, giving some technical inputs for the planned intervention. Okay, quickly, I will not be into too technical details. See, multi-slice CT is available everywhere nowadays, whether it is 64, 128, 256 slices. Ours is 128 slice CT. Initially, we take a non-contrast CT scan, followed by every word in this line is important. 40 to 50 ml of non-ionic iodinated contrast at 5 ml per second rate, and followed by a 20 ml saline chase at the same rate, preferably through right cubital vein, through a automatically powered injector, because almost hand injection is obsolete nowadays. Okay, the technically it involves pre-monitoring, that is the bolus tracking technique, which I may explain in the next slide. Typically, we acquire multiphasic CT scan, at least 3 phases, suitably timed. I will explain the reasons also. This is our setup. You can see on the right hand side, this is a power injector. You can see 2 heads. One head will contain contrast, another will contain saline. As I said, the contrast injection will be followed by a saline chase. And on the left side, you are seeing one small monitor where you program the injection. You can see 5 ml is written here. This 20 ml is the saline volume. Here, this is just after a finishing of a CT angio. That's why the contrast level is low. And how it is taken briefly, we take a scan through the superior mediastinum, put a marker in the aortic arch. The regular CT scans at 1 second interval will track the contrast bolus in the contrast density in the aorta. As contrast arrives, the density will keep increasing. We can keep a threshold, like here it is kept just below the 80 counts per unit. Once that threshold is reached, the CT will start fire, meaning it will take scans from the aortic arch to the brain. I am telling these details for certain practical reasons, because a neurology resident is the one who is sending the patient most of the time. So he has to take certain precautions in mind. Let me come to a case, acute right hemiparesis in a 45-year-old man. There are some problems in this case. Can somebody tell what is the abnormality here? Somebody from the audience? Any takers?
There is already a mark over there. Someone can just.
So there is reduced opacification at the origin of the common subclavian. Both subclavian
and which art is that?
Vertebra. Both subclavian and also in the common carotid.
So can you guess the problem? What is the disease?
So it is a large vessel vascular pathology could be there, suggestive of some large vessel vasculitis like Takayasu.
Yeah. So such problems can occur. That's why we say when you I insisted that you put a vein in the right cubital vein. If you put on the left cubital vein, recall your anatomy, it will reach the brachiocephalic vein and cross from left to right and go to the superior vena cava before entering the heart. This is the normal thing. In the process, the dense contrast can create some streak artifacts and give rise to such artifacts. You can erroneously diagnose major vessel disease. So that's why we often insist to the neurology SRRGR, you put cannula in the right cubital vein. Here the pathway is straight from the right brachiocephalic vein. It is short pathway. Here on the other hand, it is all across the major vessels. That's one point to be taken. Here, the similar reason you can see some of the vessels are missing from the arch. They are floating, major vessels, right common carotid and vertebral, everything. Subclavian is floating, and you can say the dense contrast in the right subclavian vein. This time from the right side. You can ask, he said it is from the right side only, but why it is happening? I said it should be a large cannula, 16 to 18 cannula, green or gray color cannula with high flow rate, 5 ml per second. Why it is needed? Because you can recall this image where the bolus tracking, it is firing at almost 16 seconds. You are given only that much time. You are injecting a 50 ml contrast. In 10 seconds, it should go. If you are injecting at lower volume rate, the contrast will still in the will be in the subclavian vein, and your CT angio will start to cover from the arch tube, right? And this vein, dense contrast in the vein, can create artifacts. That's why we insist that there should be a large cannula, preferably in the cubital vein, because cubital vein from the vein to heart, seconds will be 5 to 6 seconds. It will reach the heart. It should be a tight bolus. It should be a high injection rate, and that's why we are following with saline chase also to send all the contrast to the heart. Okay, what is the problem in this image? Anybody can?
Both arterial and venous phases are equally specified.
Yes. If your timing is wrong, if you are a little slow, you will get a beautiful venogram. But your aim is to get an arteriogram. And for the same reason, you should give some idea about the hemodynamics of the particular patient. If the patient has heart problem, valvular heart disease, low heart rate, cardiac output is very low, you are feeling the pulse very weak, please mention it. Accordingly, it should be, the timing should be slightly altered for the individual patient. So much about technical points. Let me come to the main area. So I said the diagnostic role is, okay, whether there is a large vessel occlusion or not, CTA will instantly tell you. Followed by a plain CT, we complete a CT angiogram typically in 3 to 5 minutes. We should complete it. This will give instant diagnosis on these areas. Let me illustrate by some cases. So, young girl coming with half an hour onset, you would have guessed it was an in-hospital stroke during thrombolysis for a mitral valve replaced case. Okay, can anybody guess what is the abnormality? Or is it normal? Listening to the previous lecture, you should, I think, fire.
Right MCL appears dense.
Very good, very good. Okay. So instantly in another 2 minutes, you are given with these images. There is an occlusion from the of right M1 MCA. Okay. Coincidentally, it will give other information about the arch, the status of vessels. You can see the young patient, every vessel is straight, no tortuosity. The interventionist would be happy to see such such an arterial system. Okay, we went ahead with the angiogram. As expected, M1 occlusion is there. Is after one pass of solitaire, and this was the final result. Patient went with almost no infarct, no deficit, also complete recovery. So site of occlusion can be confirmed instantly by the CT angiogram. Can anybody guess the site of occlusion in this case?
Terminal IC.
Very good. One basic clue is to compare with the other side. So here,
M1
M1 Here,
M2 terminal distal.
okay. M2 MCA. The clue is to compare with the other side. There are so many vessels on the other side. Okay. And an intervention radiologist will see the other side for some other reason also. Can you guess anything? Let me inform. You can see the MCA bifurcation pattern on the other side, because this side you are blind. It will give some idea about the bifurcation pattern while navigating micro guide wires and all. Okay. This is another case. So, elderly gentleman presented with 3.5 hours of right hemiparesis. This patient had seeing the CT already. Old infarcts are being seen on the other side also. So by now you would have guessed that left ICA is not seen beyond the arm. So can we take it left ICA is occluded? What about the circle of Willis? Any idea from these images?
Sir, it's filling from opposite circulation. Opposite side.
What is feeling? You can name the branches.
Sir, ACOM and
Okay. So this is intracranial circulation of the left side. Left MCA system is entirely patent. If it is entirely patent, we can leave it also. Na? We need not intervene.
left hand. Sir, filling is from opposite side ACOM and
Yeah, correct. I appreciate your answer, but
the same side ECA.
okay. So the left MCA is seen, terminal ICA is also seen through probably filling through collaterals from opposite side, or even through ECA collaterals it could have failed, or from PCOM also. But you are seeing significantly that distal M1 is occluded.
Yes,
The
sir.
coronal image also you can see. So you have to intervene. Okay, you can. So entire circle of Willis, entire MCA system is pattern. You can leave it also raising the pressure. But here there is two level occlusion. One is at the carotid level, another is distally at the M1 distal M1 level. And these lower panel 3 images show there are good collaterals. So this patient has a good chance of good functional recovery if you intervene. So that's what happened. We did the ICA is occluded. That is, you can see. Imagine a plaque rupture here, plaque dissection as a cause of it. We generally cross this lesion, go to the intracranial side, and open the intracranial circulation first. Then, while coming back, we have opened the stent and treated the tandem lesion lower down also. Okay. Another important information we try to glean from CT angio images is the length of the clot. That's why we take delayed images also, second, third phase images. They may show sometimes from the collaterals the distal end of the occlusion. Having here, we have measured something 2.5 centimeter clot almost. This gives an idea about what type of material thrombectomy device you are going to take. If it's a very long, exceptionally long clot, we may combine aspiration plus stent reverse techniques. Another example, these images are axial thick images. And as Ajay sir told, we have to sit in the console and play around the images in a very limited time, within minutes, to glean such information. Here it is a very short clot. I think seeing this, we will go ahead with a stent reverse in this case. And apart from this, we get some idea about the arch anatomy also, how difficult it will be. These are helpful to plan our intervention. Sometimes such carotids, especially in short-necked female, Indian females, you can often see such as short tortuous carotids. You can see the CT angio is showing this. This make your life very difficult during thrombectomy, because you cannot cross this tortuosity also, and you can't take multiple devices to distally to realize also. Okay. Another important thing is ICAT. Can you diagnose ICAT based on CT angio? It's a $1 million question. But here you can see there is an M1, mid M1 occlusion, almost stenosis, and the distal artery is filling. In such cases, you can have a guess whether it can be atherosclerotic also, but you can be never sure. As in this case, we tried, we recanalized, and you can see the plaque as on the floor of the distal M1 MCA. This closed at no time. In another 5 minutes, it closed. Similar case, an elderly man presented with right side hemiparesis. We are seeing the M1 cutoff in the CT angiogram. This axial source images see they gave the suspicion of ICAT. We went ahead, did the reconalization, only to see it progressively occlude in another 5 to 10 minutes. So this time we wanted to keep it open. We loaded with antiplatelets and opened it with a stent, placed the stent, and this is the result. This is a recent case. Patient did well. So do we stent always? This case, you can see the right dense MCA. You can see infarcts of varying ages. So one cardiac hypodensity and in the parieto-occipital watershed region also. So probably this patient had a M1 stenosis for long, recurrent stroke has been there. So same history story, we are opening, getting it uploaded. This time we thought, in view of the already pre-existing infarct, if we put a stent and load with antiplatelets, we feared a possible bleed in the infarct. So we treated with balloon plasty and treated with some antiplatelet, minimal dose of antiplatelet. You can see the perforators opening up, perfusing it. Left the patient as such. We didn't put a stent, and the patient had a remarkable clinical recovery. Another patient, 25 years old lady, present with a left-sided weakness, 3 hours duration. So somebody can read the CT.
Sir, there is a left, right MCA insular cortex hypodensity.
Okay.
And involving M3, M4 insular cortex and M.
Okay.
So the
There is some
parenchymal,
hypodensity.
can I interrupt? I think you can first describe, start from the base, go up, describe, look at the Sylvan fissure, the cisterns.
So there is a hyperdense MCA sign in the right MCA.
Good.
Then there is a Sulci-Gara effacement, hyperdense area in the territory of left MCA. Aspect score 3, 2, 3, 5. With the aspect score of 5.
Yeah, it's a poor aspect. 25 years old lady. What will be your call? Whether will you like to intervene or not?
Sir, aspect score is more, so there will be a high risk of revascular injury.
Exactly.
So
to make the aspects very clear, you can see another aspect also, that is CT angio aspects based on the collateral scoring. You can see the collateral status in the delayed phases also. Here you can see as you go to the second and third phase, this hypodensity is glaring.
yes, sir.
There are, in some young patients, this was 3 years back, this case, we have pressure to try to intervene. Even after successful recanalization, as you exactly predicted, there was some hemorrhagic transformation and this patient required craniectomy. Though we are not sure whether we benefited the patient or not, but the patient survived. That's it. Okay. I will give an example of good collaterals, how to assess it. Here, there is an M1 occlusion. You can see the successive images. First phase, second phase, you can always compare with the other side. If there are vascular channels filling up in successive phases, you understand that there are good collaterals. Such patients are worthy of intervening, as happened in this case. Okay, another case, 45 years old lady, presented with sudden right-sided weakness. Okay, this case I think Dr. Ajay also showed. Can you recall the finding? Anybody?
Sir, there is a MCA dot sign in the left MCA territory.
Yeah. There are good collaterals also, if you see on the in the second phase. Right side, the arterial has washed out, but the left side, around the temporal lobe and the insula, there are good collaterals. And this is a distal M2 occlusion. This patient was also recanalized successfully. The impact is limited here. Okay, there are multiple ways of scoring the collaterals. These are described in literature. One is seeing the ipsilateral territory, how fast it is filling in phase 1, phase 2, phase 3, how many percentage. I'm not detailing the method. So one is seeing the ipsilateral territory only and seeing the temporal profile, how fast or how slow it is filling or not filling at all, or how much area is left. This gives a rough idea of the penumbra. Of course, you can correlate with this collateral status with the clinical scoring, NIHS scoring, and come to a conclusion whether to intervene or not. This is one method. Another is you can compare with the other side and grade the vasculature, M2, M3, M4 branches. These are the things available in the literature. Let me come to the any questions so far? Okay, let me go to the CT perfusion. So the basis of CT perfusion arises, although we have often heard time is brain, but time is not the only factor affecting the chronological timing is not the only factor affecting the tissue death. There are many more other factors, physiological factors, including collaterals and tendency of the collaterals to fail often, that is unpredictable in a given patient. And cardiac status also dictates how much the collateral strength will be there. Age of the patient also decides. So there are too many confounding factors. And in a given patient, especially in our setup, it is very difficult to know the exact time when the patient was well. So what is the exact timing of the stroke in the particular patient we are dealing with? These are certain questions. So we need a tissue timing. So more functional imaging are needed. To fill this gap only CT perfusion was devised, and diffusion perfusion mismatch MR imaging can also address these questions, but you need to have a specific setup nearby MR or adjacent room MRI, like this logistical support. Short of it, CT perfusion should be a very good alternative. I'm not going into the technical detail of how CT perfusion is done. I can only say we can use 50 ml of contrast only. You can do it after a few minutes after CT angio also, or straight away in a suspected case, or doubtful stroke timing or wake up stroke, you can straight away go for CTP also. But CTP can also be reconstructed to have a vascular anatomy also. In CTP, you inject the contrast and your brain is scanned repeatedly. One scan is called one dynamic. It is given the speed of the current multi-detector CT scans, it is possible. So 22 dynamics typically in our institution, we take repeated dynamics and see the pattern of contrast from the time of injection, how it arrives to the brain, which areas under perfused. These informations we can glean. There are a lot of mathematical calculations which can yield many parameters, which include CBV, which is cerebral blood volume, CBF, cerebral blood flow, MTT, that is mean transit time. Apart from this, there are two other parameters like time to peak and Tmax. These are the various parameters, and many automatic softwares like Rapid, Philips IntelliSpace, and many software are also available, which can process these images and give you such maps on ready-made maps. There is a lot of thresholding that has to be done. This thresholding varies with vendor to vendor. Typically, one of the most popular vendor keeps relative cerebral blood flow to assess for infarct, and Tmax to assess for the penumbra. The mismatch between Tmax and relative cerebral blood flow less than 30% forms the penumbral tissue. As you see in this case, 60 years old lady presenting with acute left hemiparesis. Diffusion was done at already shows some infarcts in the left MCA territory. In CBV and CBF, you are not seeing much area wide of blood flow or blood volume, and MTT shows much larger, almost entire right MCA territory is at risk, that is slowing of flow in this hemisphere. And converting into a colored map, you can see that that this green area shows the penumbral area. Penumbra, as you might all know, indicates the tissue at risk. If not intervened, it may convert into a infarct. The red area shows the core, that is already infarcted tissue. This equivalent to a diffusion restriction area, you can imagine. This patient was recanalized. The follow-up MR next day shows a slight expansion of the infarct, but given the area at risk, I think we have sizably limited the infarct. Probably this patient was avoided a craniectomy also. So this is a basic theory. After a major vessel occlusion, large vessel occlusion, there is a central core which is irreversibly dead. A diffusion will show restriction. Here the cerebral blood flow is 10 ml per less than 10 ml per 100 gram. But this CBF absolute value is very difficult. So modern softwares mostly do RCBF, that is relative CBF, compared to the normal brain on the other side. If there is less than 30% blood flow, that region is taken as core. Followed by, surrounded by it is an ischemic penumbra. This is a schematic diagram. It is not geometrically.
You will have to conclude in less than 3 minutes time. Okay. Please.
Okay. So let me be fast forward. So if there is a significant perfusion diffusion mismatch or
Joseph will have to stop here for a minute. Okay.
Okay.
Or you finish in 1 minute's time. Okay. Please.
Okay. This lady, 58 years old lady of doubtful timing, 10 hours duration. We see a large perfusion mismatch area in this case. This patient was intervened successfully. On the other hand, another case, there is a matched area. There is no penumbra at all, though was not intervened. This perfusion mismatch can occur not only in occlusions, it can occur in atherosclerotic narrowing stenosis also, as in this case. You can see there is no penumbra as such, but there is a lot of area of slow perfusion, which may show the oligemic region rather than a penumbra proper. So this patient was not intervened, treated medically. And I think I don't have time for MRI. I think Ajay sir highlighted many of these areas. Let me show that the intravascular thrombus can be often seen in a SWA image, as seen in this case. And MRI, if done in a center, it has a capability of showing the vessel occlusion also, like CT angiograph. And in the other case, the lower panel shows the thrombus within the vessel in the SWA. And in ideal situation, in cases like wake-up stroke, where there is a problem in timing, this MR can solve the problem, like diffusion, perfusion. Here the defect is matched. And another case, small diffusion restriction area, perfusion showing lot of defect, penumbra. So this is an ideal case for intervention. And one word about diffusion flare. It also gives a rough timing, especially for intravenous thrombolysis. Here the diffusion restriction and flare areas are matched. In contrast to this case, where there is a diffusion restriction area is very large, but the flare changes are not yet shown up. This is one classical example of diffusion flare mismatch.
So I think you have already concluded your talk. So thank you very much. It was a very useful talk. You covered a lot of aspects about the advances in the imaging, especially more so on the role of the CT.